Good morning, ladies and gentlemen. The topic of my today's lecture is lasers and energy-based devices. This is the last chapter or chapter 161 of Rook textbook of dermatology. Although the chapter titles lasers and energy-based devices, but actually this chapter is concerning mainly with energy-based devices. So the lasers is not part of this chapter. And if you want to learn about the lasers and its application in dermatology and aesthetic medicine, please watch to my lectures number 105, 106, and 107. In these lectures, I have given a very comprehensive detail about the laser physiology, the laser's physics, and its various applications. So let's proceed with today's lecture, which is mainly on energy-based devices. Introduction. Lasers, light, and energy-based therapies have offered significant advances in dermatological therapy in the past several decades. To provide patients with optimal treatment, one must accurately identify the target structure and then select the appropriate lasers, light, or energy-based system, and then tailor the specific parameters for the intended targets. So understanding the machine you are using is very important to give good results, and never rely on your vendor's instructions regarding the lasers or energy-based devices. Always read about the machine and ask from your colleagues and seniors before you proceed and start using those machines. Skin resurfacing. And the two devices which are most widely used in the world for this indication are the carbon dioxide and erbium YAG lasers. The classic ablative skin resurfacing gained popularity and set the gold standards for facial rejuvenation in 1990s. The carbon dioxide laser, originally developed as a surgical cutting instrument, became the prototype device for facial resurfacing. The CO2 laser operates at a wavelength of 10,600 nanometer and targets water. The high energy, short pulse CO2 laser achieves efficient soft tissue vaporization, such as skin, when delivered above the vaporization threshold of 5 joules per centimeter square and in pulses of 1 millisecond or less. So CO2 laser could be used as a resurfacing tool when it is used at the fluence above then 5 joules per centimeter square, which is the vaporization threshold of skin. The picture shows a CO2 laser device. The vaporization is always associated with some residual thermal damage, which extends 50 to 150 micrometer beyond the vaporization zone. The vaporization zone is the zone where the skin is totally lost. Then this vaporization zone depends on the pulse duration and number of pulses delivered. Surrounding zone of thermal coagulation results in new collagenesis and skin tightening. If low fluence or sub-vaporization threshold pulses are delivered, tissue coagulation and desiccation occur instead. Only new collagenesis will occur. So this diagram will help you understand when the CO2 or erbium YAG laser pulses are delivered, there is a zone of vaporization where the tissue is completely lost. Then surrounding this vaporization zone, there is a zone which is depicted in red color which is irreversible tissue damage, that is coagulation and denaturation. Then beyond this zone is a reversible tissue damage. And then beyond this is a zone of hyperthermia where only the tissue temperature is raised. The ablation and coagulation is controlled by laser fluence and pulse width. So where there is complete ablation, which is the vaporization zone, a new skin will be coming and covering this zone, while in the zone of coagulation, there will be new collagenesis. Then about the erbium YAG lasers. The erbium, yttrium, aluminium, garnet lasers emit the light within the mid-infrared portion of electromagnetic spectrum at a wavelength of 2940 nanometer. Since this laser has the same indication as carbon dioxide laser, so it's always compared with CO2 machine. So in comparison with CO2 laser, energy from erbium YAG is 12 to 18 times more efficiently absorbed by water-containing tissue with a tissue ablation threshold of approximately 1.5 joules per centimeter square, which is 5 joules per centimeter square in case of CO2 laser. As such, this device induces much less thermal injury in areas immediately surrounding the vaporization zone that leads to faster healing, less redness, and less delayed onset permanent hypopigmentation. So this laser is also efficient in the way that it has less side effects, less downtime as compared to the CO2 laser. This picture shows erbium YAG laser. These advantages are offset by so-called cold vaporization of erbium YAG because of its relatively poor ability to coagulate the tissue. Hence, use of low power erbium YAG was thought to be less effective for anything more than superficial laser peel, as immediate bleeding will impede further vaporization. So the effect of erbium YAG is superficial as compared to carbon dioxide laser. However, when high power erbium YAG devices are used, they are efficient ablators of tissue and also have effective coagulative component that reduce bleeding. So this is a difference, that is low power or high power. High power erbium YAG will behave almost similar to a CO2 laser. After 30 years, the laser resurfacing devices still remain the gold standard for photo rejuvenation, wrinkle reduction, and skin tightening. So there is no room for surgical resurfacing anymore. The initial fervor for fully ablative laser skin resurfacing is no more because of the prolonged post-treatment recovery with increased risk of superficial bacterial, viral, or fungal infections. So the old trend of complete skin resurfacing by laser ablation is not popular anymore. The long-term sequelae of such a procedure is significant post-treatment erythema, a line of demarcation with relative hypopigmentation between the treated and untreated areas. Then a delayed onset permanent hypopigmentation within the treatment zone in 15 to 20% of the subject because of the complete loss of melanocytes in that region. Then why this procedure is no longer in favor is because of the manufacturing of these new kind of lasers, which are called as the fractionated lasers. So in fractionated lasers, we have both non-ablative as well as ablative lasers. The fractional ablative lasers are again CO2 and erbium jack, but first we are going to discuss the fractionated non-ablative devices. In an effort to reduce the treatment-associated morbidity and speeding up the post-operative clinical efficacy, fractionated photothermolysis was introduced, causing a significant paradigm shift with regards to both efficacy and safety, but mainly the safety. The non-ablative fractional resurfacing is characterized by delivery of narrow beam of high energy light using a variety of wavelengths, and again the target is water. So the chromophore is water in all these devices. The fractional photothermolysis treats a relatively small percentage of skin surface, and the depth is at which it's effective is usually not more than 1.5 millimeter. Histologically, there are clear zones of epidermal and dermal necrosis within these microscopic treatment zones, known as MTZs. The stratum corneum remain histologically and functionally intact. Thus, rejuvenation with these prototype devices is termed as non-ablative. So, any device in which the stratum corneum is not damaged will be labeled as a non-ablative device. The non-ablative fractional photothermolysis has been shown to improve photoaging, skin texture, wrinkling, dyspigmentation, telangiectasias, atrophic acne scars, traumatic scars, striae distensi, minocycline hyperpigmentation, and residual skin redundancy following resolution of hemangiomas. The first non-ablative fractional device was known as Fraxel Restore, is the most extensively studied as well. This device is actually an erbium fiber laser at a non-ablative wavelength of 1550 nanometers. This device creates these devices creates the microscopic treatment zones ranging 100 to 200 micrometers in width and 500 to 1400 micrometer in depth. Energy levels can be adjusted from 4 to 70 millijoules per microscopic treatment zone. Another device is the thallium 1927 nanometer laser, which is known as the Fraxel Dual, which increased the versatility of these fractionated devices. So the maximum depth of penetration of this device is 202 micrometer at around 20 millijoule per pulse. At this energy, the dermal thermal injury profile is similar to a superficial CO2 laser, and the main advantage is there is no epidermal loss, no exudation or bleeding. With this minimal depth of penetration, one can effectively perform superficial treatments targeting epidermal pathologies like dermatoheliosis, dyschromias, actinic keratosis, and actinic cheilitis. It is considered a significant advantage as treatment modality with low risk and particularly in darker skin types. Now we are going to discuss the more popular fractional ablative devices, which are again CO2 and erbium YAG lasers. Following success of fractionated non-ablative came the development of fractionated ablative rejuvenation. So previously, once these machines, the CO2 and erbium YAG, were introduced, they were first used as a generalized ablative tools, but when it was found that by changing it into a fractionated devices, it will create more safety and more better post-operative results. So these new devices then were introduced. The three wavelengths, 10,600 nanometer of CO2 laser, 2,940 of erbium YAG laser, and 2,790 micrometer of yttrium, scandium, gallium garnet YSGG laser were selected for this purpose. All wavelengths are well absorbed by water content in the tissue. So chromophore of all these wavelengths is water. The Fraxel repair was the first ablative fractional device that employs a 10,600 nanometer CO2 laser delivered by a scanning handpiece technology and has an ability to place 2,000 microablative treatment zones per second. The deeper effects is when another well-studied ablative fractional laser device, the deep effects utilize a narrower spot diameter but greater penetration into the dermis. Unlike the scanning delivery method, deep effects uses stamping method. So this is another method of delivering the wavelengths. Fractional ablative technology using erbium YAG lasers include the ProFraxel, Pixel, and Starlux 2940. All these devices vary from one another but based on 2940 nanometer wavelength, which is the wavelength of erbium YAG laser. This delivers light at the peak of water absorption and maximizes tissue ablation while minimizing the incidence of post-inflammatory hyper or pigmentation as well as erythema. A more recent addition to these fractional devices is a hybrid system, commercially known as the Halo, and this system combines a non-ablative 14,070 nanometer diode wavelength and an ablative wavelength of 2,940, the erbium YAG wavelength, in a single handpiece that has ability to deliver both wavelengths in a single pass. So the 1470 nanometer wavelength is absorbed by water and is capable of penetrating the dermis up to 70 micrometer. Unique to the halo is the ability to adjust the penetration depth to as little as 100 micrometer and ability to precisely target the actinic damage at 300 to 400 micrometer levels. The immunohistochemical studies demonstrate that new collagenesis after ablative fractional resurfacing. The heat shock protein 47 required for collagen remodeling persists for nearly 3 months following the treatment, suggesting an ongoing collagen synthesis long after the immediate recovery period. So many of the patients will ask you, once you will advise them about a fractional resurfacing laser, that how long will this effect last or will come after the laser. So you are going to tell them that the effect starts immediately and will keep on coming till 3 months of the treatment. The ablative fractional photothermolysis offers the opportunity for relatively safe treatment of anatomical regions that were notoriously difficult to rejuvenate with conventional ablative resurfacing and has been shown to be effective in treating photo damage and acne scars. So, we would end this discussion by saying that although the ablative non-fractional devices were used initially for skin rejuvenation, but later on it was found that if these ablative devices are converted into the fractional mode by use of scanning handpieces, then the results are not much compromised, but the safety is much increased by the use of the fractionated devices. Management of patients undergoing laser resurfacing procedures. First of all is the patient selection. Caution should be excised in treating those with history of delayed wound healing, secondary to tobacco or alcohol abuse, patient with active local or systemic infections, history of keloid scar formations, diabetes or other systemic medical conditions, malnutrition, a history of connective tissue disease, or immunocompromised status. Then isotretinoin use in prior 6 months could impair wound healing, although recently the concept has been challenged, and now we are using fractionated ablative devices in patients who are on isotretinoin low dose or who have stopped the drug a few months back. You must all understand that isotretinoin will cause dryness, increase photosensitivity, and delayed wound healing. So you have to be very careful in such patients that you are going to advise them strict sun avoidance, antibiotic ointments, and lots of moisturizers even days after the initial laser treatment. Preoperative management and anesthesia. Both ablative and non-ablative fractional resurfacing may be quite painful without appropriate anesthesia. So the application of topical anesthetic ointments such as lidocaine, tetracaine, 23 and 7%, for approximately 1 hour increase the patient comfort. Other cooling strategies like forced cold air or contact cooling enhance the patient tolerance. For more aggressive ablative procedures, additional anesthesia with nerve block, tumescent anesthesia, or systemic narcotics with anxiolytics are used. Oral antiviral therapy is generally recommended in patients with history of recurrent herpes simplex. Acyclovir or valsaclovir is typically given anywhere starting the day of treatment for 7 days post-treatment. For ablative procedures, patient may also receive antibacterial prophylaxis, usually in the form of penicillin or macrolides. We are talking about non-fractionated ablative procedures. Post-operative course. Following ablative fractional resurfacing, punctate bleeding and serosanguinous discharge is expected, which dry into a thin keratinaceous crust within 24 to 48 hours. Significant edema and erythema of treated skin is observed with both ablative and non-ablative fractionated therapies, although the latter is much less evident and its duration shorter. A single application of topical potent corticosteroid ointment immediately following the procedure can reduce these side effects. For ablative fractional photothermolysis, the erythema dramatically improves within 1 week, but mild erythema and edema may persist for 3 to 6 weeks. Most patients are able to return to their normal activities, including work, and can apply makeup approximately 7 days after the ablative fractional photothermolysis, depending upon the depth and density of the treatment. Unsightly lines of demarcation between treated and untreated skin can easily be avoided by feathering the treatment at the borders with low energy and density. One of my strategy is to do the complete face till the hairline. Non-ablative fractional photothermolysis typically require little downtime for healing, as edema and erythema resolve within a few days. So as far as the post-operative recovery is considered, the non-ablative devices are superior, but the efficacy is also less than the ablative fractional devices. The fractionated ablative system offers an unparalleled safety margin compared to traditional ablative lasers, as area of vaporization are so minute that they heal very rapidly. Up to 50% of the facial skin can be treated with these devices, and yet skin heals within 5 days, with no scarring, of course. Infection remain a significant complication and can lead to permanent scarring if not recognized and treated early. The laser surgeons should be cautious when treating areas like neck and chest, where the dermis is relatively thin and fewer adnexal structures, resulting in less robust healing. So if you are using it on the neck and chest, keep the fluence low and keep the density also low. Another important strategy to minimize the risk of scarring is avoidance of bulk heating. These devices lay down discrete packages of energy, each separated from the other by a normal untreated skin, which is basically the mechanism of fractionated devices, that they create microscopic treatment zones which are separated from each other with normal skin. Scanning or stamping repeatedly over the same area will induce bulk heating that might induce full thickness skin loss and subsequent scarring. So it is better to keep one pass at one particular area. And if you are intending to give a second pass, give it some time and change the direction of your handpiece a little. The use of non-overlapping techniques allow the treated skin sufficient time to cool before the application of subsequent pass in the same area. Now, this is another way these fractionated devices can be employed and used. And this is the laser-assisted drug delivery. Laser-assisted drug delivery uses vertical cone-shaped channels known as the microablative zones from ablative or non-ablative fractionated lasers to create a viable path for the drug delivery. You can see in this picture, we have created the microablative zones, and then we have delivered the drug to be absorbed in these zones. And the third picture is the photodynamic therapy, which is used over this system. We are not talking about photodynamic therapy here, but you can watch my lecture on photodynamic therapy I don't remember actually which is the number, but it must be somewhere in hundreds. The application of topical agents to microablative zones allow for dramatically increased penetration and bioavailability of medications like triamcinolone and 5-fluorouracil. The coverage of skin should be less than 5% to prevent a toxic systemic absorption of topically applied medication. So, no large surface should be treated in this way. The holes created by microneedling or radiofrequency microneedling tend to close immediately, and one should understand that the rapid rate of absorption through the skin limits the agent used as the drug in this method. So, immediately apply the drug to be delivered on the treatment area. Hypertrophic scars treated with laser-assisted drug delivery. Combining the ablative fractional resurfacing with both intralesional and topical medications has shown promise for the treatment of keloids, and hypertrophic scars. The most commonly used medications include intralesional triamcinolone, topical triamcinolone, and topical 5-fluorouracil. There was no statistically significant difference between the triamcinolone and 5-fluorouracil. Rhytides treated with laser-assisted drug delivery. Perioral rhytides are stubborn to treat. Ibrahim and colleagues demonstrated the efficacy of 3 treatment with low density, fractionated ablative CO2 laser and topical application of poly-L-lactic acid to upper cutaneous lip rhytides and had a 47% decrease in their severity. Melasma. Melasma remains a challenging disorder to treat. The current treatment regimens show varying degree of improvement and recurrence is expected despite strict sun protection. Melasma is always a very difficult case for all the dermatologists and aesthetic physicians. The laser management. Using fractionated, non-ablative lasers describe clinical improvement of treatment-resistant facial melasma after 2 treatments. The clinical improvement correlate with appropriate histological findings of melanin extrusion in the dermis and epidermal necrotic debris. The more recent reports have suggested some limitations in efficacy with high recurrence rate after treatment, especially in those patients with darker skin types. The ablated fractionated treatments can be useful for melasma when used in combination with topical bleaching agent by increasing absorption, for example, hydroquinone. Given the melasma is a disorder of hyperpigmentation, there is some rationale for use of very short pulse Q-switch or QS lasers. The low fluence treatment with Q-switch 1064 nanometer Nd:YAG laser is currently used, causing fragmentation of melanin granules and facilitating their removal without cellular destruction. So Q-switch 1064 nanometer laser is the prototype laser used for the treatment of melasma. Coe and Goldberg et al. In separate studies demonstrate the efficacy of low fluence 2 to 3.5 joules per centimeter square Q-switch laser at 6 mm spot size. After 5 to 8 treatment, 1 to 2 weeks apart, the pigmentation is significantly decreased. Cohort treated 27 female melasma patients with combination of microdermabrasion, followed immediately by treatment with low fluence laser. After an average of 2.6 treatment, 81% of the patients have greater than 75% of clearance. More recently, there has been increased use of pico lasers for the treatment of melasma, in particularly with low fluence. repetition rate, and density. So always remember that whenever you are using Q switch or pico laser, use it at low fluence in which there is mild degree of erythema. But no, there should not be any visible damage to the epidermis. The lasers and light-based devices are not the first line of treatment for melasma, and caution should be taken when using these devices that applies too much heat to the skin. Of note is Of note, while intense pulse light is often used, it can exacerbate melasma. So better not to use IPL in melasma. Cryo modulation technology. This is again a new technology which is not very common but is already introduced in our country and in neighboring countries. The cryomodulation technology provides an intriguing new way to lighten, brighten, and rejuvenate the skin. This novel approach treats benign lesions with precision using controlled cryo-based technology to reduce melanin production while maintaining the melanocyte viability. The skin barrier remains intact, ensuring effective treatment without the disadvantages which are associated with comparable treatments like the fractional ablative systems. Skin tightening. FDA has had some difficulty in redefining this process. Significant research has focused on the radiofrequency and high intensity focused ultrasound. Other research has investigated the role of bulk cooling, deoxycholic acid, both of which provides limited evidence for skin tightening as a part of fat reduction process. Then shock wave therapy is used in some spas for skin tightening but has little specific basis of relevance. Traditionally, the best understood skin tightening is with CO2 and erbium yak resurfacing, but such kind of resurfacing reaches to the depth of only 300 to 400 micrometer, which can cause epidermal tightening. But the newer radiofrequency and ultrasound technologies attain a depth of 2 to 6 millimeter, reaching up to superficial musculoaponeurotic system or SMAS layer. When comparing the relative benefits of depth versus density, it is the later, that is density, which is more important for the tightening. RF can be used to induce the volumetric heating at selected depths by changing the frequency and configuration of the electrodes. Water is again the target, and the depth of penetration being inversely proportional to the frequency that range from 3 kilohertz to 24 gigahertz. The configuration of these devices can be either bipolar or unipolar. We are talking about the radio frequency devices. Localized heat injury at specific depths will induce an inflammatory reaction resulting in new collagenesis, new elastogenesis to achieve wrinkle reduction and tissue tightening. Of note, care must be taken to avoid excessive heating of the subcutaneous fat, which may result in localized fat depression in the skin. And sometimes this fat depression will result in unequal or unnatural fat loss that will create the bad effects rather than good effects on the facial skin. Methods of radiofrequency delivery. The monopolar devices use a grounding plate, which is attached to the patient's body so that the energy is delivered through the skin to the patient, into the body, and then ultimately to the grounding plate. These are the monopolar devices. Other popular RF devices are the continuous or dynamic delivery techniques with constant gyration of handpiece by the operator while the pulse fires continuously. Constant surface temperature monitoring or the patient's own protective sensory mechanism for pain while delivering radio frequency to avoid overheating is must. So if a machine contains the surface temperature monitoring, this machine will be preferable. But if the patient says that he or she is having pain, then that should also be taken as the maximum beyond which you should not go for this treatment. Otherwise, you will induce skin burns. Temperature above 41 degrees centigrade are generally not well tolerated in these devices. The first monopolar radiofrequency device which was cleared by FDA was Thermage. In 2004, it was approved for treating periocular wrinkles. Other indications include the sagging jowls and body tightening in abdomen and thighs. Through a process called as the capacitative coupling, the device can heat the dermis up to 65 to 70 degrees centigrade at a depth of 2 to 6 millimeter while maintaining the epidermal temperature between 35 to 45 degrees centigrade. Electron microscopy has shown an increase in diameter of collagen fibers in post-treatment biopsies. Non-randomized, non-blinded studies have shown subjective improvement in lower face skin tightening, in submental laxity, cheek laxity with these radiofrequency devices. These are two monopolar radiofrequency devices by BTL. This is Vanquish Me and this is Axelis 360. Bipolar radiofrequency devices use two electrodes within the handpiece so that the radiofrequency wave travel between these alternating positive and negative poles. Spacing the electrodes at certain distance determines the depth of penetration. Studies have shown that 25 to 50% improvement in wrinkles, skin smoothness, and texture with these devices. The objective of combined light and bipolar radiofrequency devices is to create more efficient tissue heating. This is one of those devices in which bipolar machine is used. That is Ascent E-Light Pro by Alma Laser. Safety and adverse events. The high-quality radiofrequency devices have excellent safety profile, largely attributed to the advantages in the real-time monitoring of tissue impedance. By adjusting the power according to the impedance, that is resistance, the operator can avoid overheating and blistering. The practitioner should be aware that there are multiple inferior copycat devices purporting to be effective and safe, but neither it's effective nor they are safe. So always use the best devices in such cases. And I have seen many patients receiving unsightly burns if these devices are not properly manufactured and have cheaper brands. The most common side effects with monopolar radiofrequency is erythema and edema that last for 24 hours. Some serious side effects include superficial crusting, atrophic depression, erythematous papules, and tenderness. It must be kept in mind that all radiofrequency devices are indicated for mild to moderate skin laxity, and excess subcutaneous fat tissue should not be managed with these devices. Ultrasound machines. Ultrasound is established as technique for non-invasive tissue tightening, though the enthusiasm for this depends on the experience of the health provider. The primary mechanism is tissue absorption of very brief focus and longer diffusing acoustic energy. Skin pigmentation does not impact ultrasound and thus can be used in all skin types. High intensity microfocus ultrasound, HIFU, or UL therapy provides approved for improvement in appearance of facial, neck, lines, and decollete. There are depth-specific transducers, induce millisecond pulses of local injury within the skin without damaging the epidermis. The targeted approach has good clinical improvement. Side effects are focal bruising, significant pain during the treatment. Anecdotal evidence suggests high patient motivation is required to endure this process because if we are doing it at the proper way, then it is quite a painful process. Soft wave provides more diffuse ultrasound, mid-dermal heating at 60 to 70 degrees centigrade, maximally targeting the depth of 1.5 millimeter for 5 seconds without damage to underlying structures like bone, nerve, fat, and blood vessels. Advantage of these devices is related to its relative simplicity with no disposable, no moving parts, and no optics. The parallel delivery of more diffuse ultrasound beams, integrated cooling, and large contact area allow for less discomfort and faster treatment. Large zones of volumetric heating measuring 1.5 to 4 millimeter from each of the 7 transducer targets the middermis, and as such, speed of treating the entire face is about 30 minutes. So in 30 minutes, you can deliver a complete treatment for the face. There are both immediate and delayed response, initial plumping of the skin with better reflectance and general appearance followed by tightening. The process takes several weeks, at least 6 to 8 weeks for its full effects. As with most cosmetic treatment, photographic evidence of improvement is critical for acceptance of real benefits. So always take a pre-procedure photograph of such patients. Ultimately, it is the patient who decides whether the benefit is worth the time and financial investment. Radiofrequency microneedling. This is a newer technology in which the radiofrequency wave is delivered by a microneedling device and has become a popular treatment for facial rejuvenation. It is also useful for acne scarring, especially in dark skin patients, because this technique has very less downtime and side effects. The devices can be monopolar or bipolar. Also, the electrodes are either insulated or non-insulated. So there are few machines in which the electrodes are insulated, in some there are non-insulated, while there are other machines in which both kind of electrodes are used. Most disposable tips have approximately 50 electrodes in a square configuration. These devices demonstrate to induce new collagen and elastin formation in the mid-dermis and improve skin laxity on the face. So they are popular in treatment of the face. So this picture shows 3 most popular microneedling radiofrequency devices used in this country. That is, this first one is Morpheus, second is Silphem X, and third one is Vivasi. In general, the radiofrequency microneedling device are performed 4 to 6 times at 1 month interval using topical anesthesia. The needle density and length are sufficient to provide both superficial and deep controlled thermal injury. We can adjust the depth of penetration of these needles as well as the energy in all these devices. The best part is the low downtime, lack of post-inflammatory hyperpigmentation, and use in all skin types, making these devices quite popular. This technology is used for skin rejuvenation in subjects, has seen improvement in skin tightening, smoothness, and in wrinkle reduction. Body contouring. The body contouring refers to optimization of the definition, smoothness, and shape of the human physique. Apart from the underlying skeletal frame, this mainly involves the muscular definition and distribution of subcutaneous fat. There are several non-surgical aids that can provide convincing improvement in appearance. Muscle definition. The electromagnetic muscle stimulation, also known as the EMMS, selectively delivers strong electrical pulses to the muscle tissue, dramatically increase the muscle contractile force. Whereas the skin and fat are poor conductors, muscle is an excellent conductor, resulting in straightening, toning, firming of the muscles of abdomen, buttocks, and thigh. Patient will notice almost immediate improvement in contractility, although this is not permanent. This is one of the machine which is known as the M-Sculpt, which is based on this EMMS technology. There is some debate regarding the role of EMMS in reducing the localized fat, as the fat lies between the skin and the muscle. So this is still a debate, and it is claimed that there is a reduction in fat by use of these machines. But even if there is no reduction in fat, the fat will be remodeled or contoured by if these devices are used for muscle stimulation. Fat contouring. Historically, the approach to body contouring has largely involved invasive procedures like liposuction and abdominoplasty. In recent years, patients have sought procedures with minimal downtime and little or no associated risk, despite the fact that such procedures are less effective than traditional surgical approaches and require repeated treatment. So there are many patients who do not want to go for the invasive procedures or are unfit for such procedures. They can all use these energy-based treatments for treatment of these bulky fat pads. Current non-surgical body contouring devices include those that induce bulk cooling, known as the cryolipolysis, or bulk heating, known as the thermolipolysis. Low-level laser therapy, low-energy non-thermal ultrasound, and HIFU have also met with some success in fat reduction. Bulk cooling or cryolipolysis. The concept of cryolipolysis was introduced in 2007 and cleared by FDA in 2010. The cryolipolysis applies a controlled cold exposure with cup suction to induce the targeted apoptotic reduction of subcutaneous fat. The technology is based on the concept of popsicle panniculitis, in which the cold induced the inflammation of the subcutaneous fat, resulting in apoptosis. By controlled and modulating the cold exposure, it is possible to damage adipocytes selectively while avoiding the damage to overlying epidermis and the dermis. The decrease in fat thickness occurs gradually over 3 months and is more pronounced in patients with limited and discrete fat bulges. Multiple clinical trials have demonstrated an average of 22.4% reduction of fat layer thickness. The known risks of this procedure include discomfort during the procedure, erythema of the skin, bruising, temporary numbness with no long-term effects on the function of the peripheral nerves. Contraindications include patients with cold-induced dermatological syndromes like cryoglobulinemia, cold-induced urticaria, Raynaud syndrome, and paroxysmal cold-induced hemoglobinuria. The bulk heating or thermolipolysis. Localized bulk heating of fat have been demonstrated to be effectively induce an apoptotic reduction in adipose thickness. Two best developed devices are 1060 nanometer laser, which is known as the Scalp Shore, and a radiofrequency device known as the True Scalp. In the picture, Vanquish Me is shown, which is a radiofrequency device again. One marked difference between the two concepts is heating tends to cause pain, while cooling simply results in sensation of skin numbness. So with thermolipolysis, there will be pain, and while cryolipolysis, there will be numbness. Again, the copycat imitation of these machines can cause unsighted tissue burns and scar, so should be avoided. Cellulite reduction. Cellulite is a very big problem in Western countries, and it ranges from slight rippling irregularity of the skin surface to major depressions in soft tissue, most frequently in thighs and buttocks. It is related to tethering of the fat compartments to the underlying fascia. Rapid acoustic pulse (RAP) technology uses ultra short, high energy acoustic pulses, which are also known as the shock waves, to induce the shearing stress on the tissue that are relatively solid and fixed in comparison with surrounding tissue. So the fibrous bands are broken by these high energy acoustic pulses. Indeed, its major use in future will be for disruption of subcutaneous fibrous septas and smoothing of the rippled and dimpled appearance of the cellulite. There is good evidence that high intensity, high frequency, ultra short acoustic pulses are capable of disrupting these facial connections, rendering the dimples less evident. Other cellulite treatment. Another FDA cleared treatment of cellulite is the cellulase, as shown in the picture. Cellulase is a minimally invasive 1440 nanometer laser procedure designed to interrupt the fibrous structures responsible for development and persistence of the cellulite. This side-firing side laser involves the insertion. This is another device in which a cannula is introduced directly under the skin and is set to deliver the laser pulses inside the skin. It is said to increase the thickness of the skin while simultaneously releasing the fibrous bands. Selfina worked by detaching the fibrous septa using very thin blade insertion through fine incision with local anesthesia. The dimpled skin is suctioned up into Cellulite device, allowing a stable platform under which the blade mechanically separates the fibrous bands, as you can see in this picture. It's indicated for long-lasting cellulite treatment, particularly for larger and deeper cellulite, results lasting up to 3 years. There is some swelling and bruising, but results are noticeable within few days of the treatment. Nano-pulse stimulation technology. Nano-pulse stimulation (NPS) technology is a novel energy modality that has demonstrated a unique mechanism of action that targets only the cellular morphology while sparing the non-cellular stroma. So the nano-pulse technology targets the cells and not the intervening areas. Each electric pulse is delivered over an ultra-short billionth of second time via the microneedling array, resulting in internal organelle disruption and cellular apoptosis, which is the regulated cell death. The cell-specific effect is non-thermal, with typical nanopulse delivering up to zero point 0.1 joules of energy distributed across a significant volume of the tissue. There have been clinical trials to clear non-genital warts, seborrheic keratosis, sebaceous hyperplasias, as well as superficial basal cell carcinomas. Initial results indicate that high rates of benign lesions clearing with low incidence of scarring. So this is a new technology which is found to be effective in treatment of various benign and malignant tumors. So this brings me to end of this talk. I hope you enjoyed this lecture, which was primarily on the energy-based devices. And I thank you all for a very patient listening, and be tuned to my channel for further new lectures. Thank you very much. Goodbye and have a very good day.